Thank you for coming. Thank you for coming. Great energy in the room. I like it. My name is Christy Hudson. I work here in the Public Health Division, the Director's Office. Thank you so much for coming to Public Health Week and participating. I hope you've been able to check out a number of the events that have happened this week to provide space so we can all get together and talk about health equity and cultural responsiveness. We've got some great panelists today to join us, and before I introduce them, just want a few reminders about Public Health Week. There's passports to prizes if you work in the building. You can turn those in, I think, by tomorrow, end of day tomorrow. We'll be drawing prizes on Monday. The Health Equity Scavenger Hunt is still going on, so I encourage you to play if you haven't. That's being put on by one of the student interns from De La Salle High School. Instructions are being sent out in the daily emails. If you're into the social media, hashtag this is Public Health OR. You can tag that to let people know about the great conversations we're having here in public health and just the great work that we do, right? This is about celebrating our profession and what we do. So please think about that. And what else? Oh, evaluation. We'll be sending out an evaluation early next week via email. So please do look for that. Take some time to complete it. The feedback really helps in putting these events together. So we appreciate your feedback. So with that, I'm gonna get us started. Today's event is From Policy to Practice, Increasing Healthcare Access for Immigrant Communities in Oregon. The 2017 legislature passed two very important bills that I'm sure many of you are familiar with. That's why you're here. House Bill 3391, the Reproductive Health Equity Act, and Senate Bill 558, Cover All Kids, have very important impacts on Oregon's immigrant communities specifically. So we got a panel of community partners. They're going to tell us a little bit about the implementation of those policies and how that's going, the challenges, lessons learned, best practices for engaging immigrant communities, what they're learning through their process, and hopefully we can all learn from them. So we're going to hear about both of these bills, and then hopefully we will have some time for Q&A, and also for people on the live stream. Hello, welcome, thanks for joining us. You'll also be able to get your questions through the live chat. So a little bit about these fabulous people in front of you. I'm going to start here left to right. Aldo Solano is a DACA recipient, currently serves as the Advocacy Director for the Oregon Latino Health Coalition. The OLHC recently led a multi-year campaign to pass Senate Bill 558, the Cover All Kids bill. And this extends healthcare coverage to undocumented children in Oregon. Before becoming OLHC's Advocacy Director, he played a key role in leveraging community voices and engagement as the field coordinator for the Cover All Kids effort. Aldo has extensive experience with electoral and community-based organizing work around the areas of farm worker rights, immigrant rights, youth empowerment, and education. To his left, Josie Silverman Mendez has over 10 years of nonprofit and state government experience, having supported numerous community and global health initiatives working to advance health equity and social justice. Currently, she is DHS lead for Senate Bill 558 and the program implementation of that bill, leading a statewide effort to connect immigrant children and teens to full Oregon health plan coverage for the first time. Josie was born in Idaho, grew up in Oregon, and has lived, studied, worked, and volunteered lots of places, including New York City, South and Southeast Asia, and Central America. She's got a bachelor's degree and also a master's in public health from Columbia University. To her left, Brave Program Director Amy Casso. Did I get that?
Yes.
Yes, brings 2 decades of organizing, program, and policy experience to her role at the Western States Center. She's currently the staff lead for We Are Brave, Building Reproductive Autonomy and Voices for Equity, which is a reproductive justice capacity building initiative where she was involved in the development and passage of the Reproductive Health Equity Act. She's got an MPA from the University of Washington and a BA from the University of Oregon. She's been recently featured in some really awesome publications, including the Washington Post, Think Progress, Bustle, Refinery 29, and Mother Jones. Finally, Leslie Ubel works here with us in public health. She's a systems development and policy specialist and health promotion team lead. She has got 25 years of state and local public health experience, including 2 years with the Ministry of Health in Ecuador. Her work is focused primarily on sexual and reproductive health and maternal and child health issues through an equity and cultural competency lens. She's got a bachelor's degree and a master's in public health from the University of Washington. Welcome, everybody, and I think we're going to turn it over to Aldo with Senate Bill 558.
Yes. Where are we at? The campaign. Actually, let me go back real quick. I wonder if there's anybody in the room that's in that picture. Maybe I got the wrong picture. Okay, I did. Yeah, that was the first hearing. So I'm going to talk about the effort to pass Senate Bill 558. Again, my name is Aldo Solano. I'm the Advocacy Director for the Oregon Latino Health Coalition. And I started working with the campaign through last year, even though this campaign has been in the works really for multiple years, specifically 3 years as a policy. And Senate Bill 558 did two things, if you get anything out of this. And I know most of the folks in the room are familiar with Senate Bill 558, it'll cover all kids. The first thing that it did is it expanded the definition of a child so that more children in our state were able to access the Oregon Health Plan, regardless of immigration status. Pretty straightforward, something that was left behind in 2009 through the Healthcare for All Children Act, that the community spoke to us, and we decided we were going to go for it and try to fix that for them so that kids were able to access this. The second thing, and equally as important, section of the bill, Section 2, requires DHS and OHA to convene an external stakeholder work group to implement and advise culturally and linguistic specific strategies for the implementation process of this bill. Understanding the population that we are serving, it's so crucial to be able to have a group of people who already work with that given population in order to ensure that after you expand access to a certain program, that's not just sort of there and folks are going to come in and sign up. That we need folks who are that those community members trust to give that warm handshake into the process and into the signing up for the program. So a little bit of the history. Again, it passed. We were able to pass it in July of 2017. It was effective January 1st of 2018. But again, like I mentioned before, it was a process of a couple of really multiple years, even before my time as a field coordinator for this effort, the final year of the campaign. And a little bit of history there. 2009 Healthcare for All Children Act. Again, it did really what it did. It defined what a child was under Oregon the state of Oregon's Constitution as one that is legally residing in the state. So that little play of words there left out about 17,000 children. So 2015, first, the Oregon Latino Health Coalition introduced House Bill 3735. It was a hard campaign. I wasn't there, not working with OHC, but I was volunteering. And at the end of it, we couldn't get it through that year in 2015, but we were able to allocate about $10 million to reinstate the safety net capacity grant, which is great. From there on, the forward thinking was about thinking that the program that would be created through the safety net capacity grant would be sort of a stepping stone for us coming back and really giving the full-on access that these kids deserve. 2016, the Oregon Latino Health Coalition worked really to expand the coalition and broaden the support across the state so that we could finally come in and get it through in 2017. So we grew our coalition to include more than 90 organizations and different entities across the state, including community-based organizations, health insurers and providers, faith groups, just anybody you can think of was on board with this. Why wouldn't you be? And in 2017, we passed, yay, Senate Bill 558. So we were able to get a bipartisan, bicameral bill passed in the 2017 session. That was a very historic session for us, and we ended up becoming the 7th state in the country to expand healthcare access to undocumented children. So challenges and lessons learned from the campaign itself. This is something that was before my time, but one of the things that was evident from the first time that it was introduced is that we needed to broaden that coalition that I mentioned to bring in more groups, besides just, besides the mothers of these kids coming in and into the Capitol, we needed more people to back us up, people with different types of powers and privileges to come in and advocate for the health of these kids as well. So that's something that we worked on. But it was a challenge to bring in those folks because it's something that normally community-based organizations and the families themselves are not used to working alongside with. So this is kind of a new sort of approach to advocacy. The community voice obviously was always as important as ever, and I highlight that especially in 2017, given the current political climate and kind of the how fresh it was during that time, how crucial and difficult it was to be able to go to communities that are in the shadows, that are afraid, are experiencing a lot of trauma in a time that we really haven't been in this country, at least not in my time, I've never experienced. So it was a big challenge to come around, and especially for myself personally speaking, to as somebody who grew up undocumented and is undocumented or a DACA recipient, to go in and look at a family in the eyes and tell them, you're trying to do this for your kid, right? And we're gonna try to make this as safe as possible. You can come in and we're gonna come and share your story with me. We're gonna use this as leverage so that we can get that sort of access to your kid. And understanding the pain that they're going through themselves, because I'm going through that at the same time, was especially challenging. But part of during the advocacy in 2017, the whole campaign was to ensure that that this bill wasn't watered down in any way, that Section 2 was kept in there, so that we can do the appropriate outreach for this program. That was always the intent of this bill. That was always what the families asked for from the very beginning, even before this bill had a number. So that was super important for us to highlight throughout 2017. And this is how we came into partnership with the community outreach program that Josie's going to talk a little bit more about as far as implementation and how we've been working together.
Thank you, Aldo.
Yeah.
So again, I'm Josie Silverman-Mendez, now actually with DHS, a member of the Community Partner Outreach Program. We used to be at OHA, but we've transitioned. So before I talk about sort of early implementation of Senate Bill 558 on the state side and what we've been doing programmatically, I'd like to talk about the broader sort of program that we're inserted into. So the Community Partner Outreach Program. From 2009 to 2012, we were the Office of Healthy Kids. If folks remember Healthy Kids, I've learned that some of our cards still reference Healthy Kids, which gives me some pain. But anyway, it no longer technically exists. But we were the Office of Healthy Kids. And as you likely know, Oregon had a lot of success in the community outreach that was done around CHIP expansion and getting more kids covered through that effort. So when Medicaid expansion was upon us in the early days of Cover Oregon, it was decided at that point in time that Cover Oregon would basically annex their Navigator program or their outreach and enrollment program to the state. So we transitioned from being the Office of Healthy Kids to being the Community Partner Outreach Program for the state of Oregon. We all remember what happened with Cover Oregon from 2013 to 2014, but I can't underscore enough. While it was a massive technology failure, it was an incredible enrollment success, and that really is to credit all the community partners that really rallied together to make sure folks were ultimately connected to coverage. And then in 2015, as Cover Oregon was sort of winding down, OHP came back to OHA in terms of administration, and then as folks likely know, the Oregon Health Insurance Marketplace was then transitioned over to the Department of Consumer and Business Services. So in that transition, our team remained the Technical Navigator program under the ACA, again for community-based outreach and enrollment, both for the Oregon Health Plan and qualified health plans. In 2017, thanks to the advocacy of the Oregon Latino Health Coalition and others, we also had the privilege of administering the Safety Net Capacity Grant Program. So that happened last year. Make sure my slides coincide. In a nutshell, in terms of, again, what our team does collectively and sort of this broader infrastructure of partners that all of this is being inserted into, again, we train, certify, and support organizations across the state, whether they be community-based organizations, provider entities, what have you. We have a really diverse network of partners that are trained, certified, and in community on the ground, helping folks navigate health coverage, application, enrollment, renewal, all those things that come with that. Collectively, we have over 1,000 individual application assisters, again, in community on the ground, helping folks every day navigate health coverage. I can't stress enough in terms of the bridge that our sort of team serves as. We are that bridge between community partners and the members directly that we're serving, and the state system, and every day trying to make that outreach and enrollment system eligibility process work better. So the Safety Net Capacity Grant Program, which I had the privilege of running last year, it actually operated originally within OHA from 2011 to 2012. It went dormant for several years and again was brought back thanks to advocates that were pushing forward Cover All Kids legislation at the time. It was always intended to be a bridge or a pathway to eventual Cover All Kids passage if and when that happened. So we operated the program again last year from January through December. We did a whole lot of stakeholder engagement, although wasn't officially there for some of that, but you came in kind of towards the end. But to really get that program sort of better formed and ready to operate. What was really different this second time around is that we not only grant funded safety net clinics directly, but we also funded community-based organizations. And their task was to do all of that deep community-based outreach to get the word out and say, there are federally qualified health centers and other nonprofit health clinics across the state of Oregon that you can access for free primary and preventive health care services and connect those kids through referral to those clinics. We pulled off a lot in a very short amount of time, but part of this effort in terms of community engagement early on was really looking at the language we were using to get the word out, how we were marketing and spreading the word through outreach. So we renamed and rebranded the program I'm Healthy, or Soy Sano in Spanish, maybe some of you have heard of it, and had, again, quite a lot of success in a short amount of time. Again, huge credit to our community partners that were doing the on-the-ground work. So some lessons learned, and we were lucky to have that experience last year in terms of how to successfully craft an outreach effort to connect this population to healthcare services. Fear of immigration enforcement is front and center in all of this. That was the #1 barrier our partners experienced in doing outreach last year. It continues to be the #1 barrier we experience this year. That was definitely heightened by this sense of this being a government-run program. So last year, we were not a public medical benefit program of any kind. We were, at its core, an outreach program that was, again, connecting kids to services they've always been entitled to access in the state of Oregon. We designed the program with a lot of tender love and care, I like to say. So as low barrier as possible. To date, we have no idea who any of the kids on the state level were that engaged in the program. We never collected any immigration status data as part of the referral process for the program. And still, there was all of this fear about engaging in a program of this nature. Repetition is critically important. So we've gotten some of the early data back from last year. On average, across about 32 partners statewide, it took 100 outreach attempts to generate just one program referral. And again, we're connecting kids to services presumably they've always had access to, right? 75% of those patients that were connected to a clinic for services, they were already existing or established patients within the safety net clinic system. We didn't have a lot of time, right, to really make a dent in terms of connecting patients that weren't already connected to services. But again, it starts to paint the picture how critically important community-based outreach is to programs such as this. We also heard a lot from partners that when they were, hitting the ground running with materials and talking about, the fact that kids can access these free services, that they were often met with this response: "This is too good to be true. I'm so accustomed to not qualifying. I'm so accustomed to my children not qualifying. Can I trust this? Is this some sort of trap?" So we really had to work to, combat sort of that too good to be true reaction. Trusted relationships that was key. I mean, I could speak all day about that, but that is the best tool we have. And those trusted relationships, they don't rely in government employees, they rely in community-based organizations. So, our partners were not only key community gatekeepers in this effort, but they were connected to other key community gatekeepers, and so they were able to sort of mobilize at a local and regional level to be ambassadors for this work and get the word out, reinforce that it was a real program, that it was a safe program to engage in. One-on-one outreach was by far the most effective form of outreach, and that was a big learning curve for our program. We were very accustomed to doing like large enrollment fairs, health fairs, inserting ourselves into large community gatherings. That does not work for this kind of program. So again, sitting down, having a trusted conversation with someone you know and trust to have your questions answered, that is the most effective outreach strategy. And what we learned is when one family had a good experience and went back to community and shared that good experience, it spread like wildfire in a really good way. So again, one-on-one, word of mouth, trusted messengers. System navigation. So we also learned a whole lot about that. So unfortunately at this state, I think we have this mentality that if we build things, people will just come, and I'll talk about this again in a second. That is not the case. It was one thing to connect kids to clinics. It was a whole nother thing to try to really establish this sense of a primary care home, right? And so again, our partners did so much, follow-up work, literally attending appointments with clients, introducing them to different clinic staff, walking the clinic with patients so they could get oriented to the clinic system and how sort of things worked from intake to the appointment to discharge, what have you. And it takes a lot of follow-up. So data I've seen as of yesterday across, again, about 30 partners, they collectively did more than 4,000 hours of follow-up just to make sure those referrals were met and that families had the support they needed in navigating the system. We also learned that our demographic in terms of who we're reaching through our program, it is an older youth population on average. So average age was 12 years old last year. When we engaged with stakeholders early on in the program when we were developing the messaging and some of the marketing material, they told us to use inclusive language. So don't reference the population as kids, which is so ironic because they're talking to the former office about the kids. But to not reference the population as kids, but children and teens, so as to not alienate an older youth population. And again, when we think about outreach, it's not just talking to parents then in that regard, it's also at times talking directly to teens. And so how do you tailor your message depending on who you're speaking to? We also learned a great deal about growing indigenous communities that are coming every day from Latin American countries. So notably, there's growing pockets of Hmong population. So Hmong folks come from northern Guatemala and southern Mexico, but they're coming to Oregon in large numbers every week. We have growing pockets in the Cottage Grove area, Lincoln and Washington counties, and then also in Umatilla counties. What we learned through that is the state has done next to nothing to effectively reach any of those communities. And the best example I have of that is when I tried to get material translated into Hmong and the types of barriers that we experience. So again, very eye-opening, but tons of potential from an outreach and engagement perspective. So taking what we've learned and transitioning to Senate Bill 558 implementation, we were really lucky because we had an infrastructure in place that we were able to build from. So we leveraged that community-based outreach infrastructure. We'll talk about towards the end a lack of resources for this work. Unfortunately, when Senate Bill 558 was passed, it did a lot to emphasize the importance of outreach, but it didn't fund outreach. So that was really unfortunate. And so what we ended up doing, there was funding in the bill to support staff for this effort on the OHA side. So we were able to take all of the money and divert that to create a grant program, basically. And so we were able to continue to fund 15 community-based organizations through an outreach and enrollment grant program specific to Senate Bill 558. 11 of the 15 organizations that we're funding this year for that work were Soy-Sano partners last year. So again, they've already been engaging in this work and just really building from what was accomplished last year. To supplement that, because 15 organizations statewide, when you keep in mind how much repetition it takes from an outreach perspective to do this work day in and day out, 15 is not a lot of organizations. It's about 15 staff too when you look at how the money broke down. To supplement that, we also partnered with all of the federally qualified health centers across the state, in addition to some of the general community partners that we fund through another bucket of money through our program to do outreach and enrollment work. And so we've been able to blanket the state with this specialty network that we call it. And so those other partners are on hand, they've been trained, they're mobilized, they're ready to help if folks, if they're encountering folks that need application and enrollment assistance. We've also continued to heavily prioritize stakeholder engagement. We would be nowhere without our partners, notably the Oregon Latino Health Coalition. So Aldo and Linda, who's back there, they are co-chairs for our Senate Bill 558 External Stakeholder Work Group. I mean, we would be dead without them. We could do nothing without them. So that has been critically important. And it was brilliant that they built into the actual legislation requiring the state to put together an advisory group of that nature, because it gives us sort of the meat we need to do the things that we need to do. So, good job. In terms of lessons learned and best practices, so again, our stakeholder work group has been vital to this work. We started convening them last October. The first thing we sat down to do was really design what was this campaign going to look like in terms of, messaging, marketing materials, what have you. So asking basic questions like, what do we call this? How do we explain it? If you are not accustomed to qualifying for OHP or full benefits, how do you explain what this is? Who are we messaging to exactly? How do we tailor that message? And then what's sort of the call to action? How do we connect kids that might qualify to those assisters that can help them get connected? One of the early sort of pieces of feedback that was really interesting was that we should call this what it is, which to some is revolutionary, but we should call it the Oregon Health Plan, because that is what it is. Some folks still continue to reference it as Cover All Kids. We've retired that name, so Cover All Kids was the name of the advocacy campaign, and this is the Oregon Health Plan. And so when we decided on that, the next question was, well, then how do we explain what's changed, right? And so we have this sentence you can read up here, but basically starting January 1st, 2018, the Oregon Health Plan, or OHP, is available to more children and teens younger than 19, regardless of immigration status. So that's how we're explaining, the change. We, from there, developed sort of this core message frame. We did not only a lot of feedback gathering and testing with our external stakeholder work group, but we also did 2 focus group sessions with community directly. Some really encouraging things that we learned through that work. OHP is a trusted brand, which was great, and that we were on the right track. People far prefer calling than going online for information. So, little things that we would tweak sort of in the message frame. We'll have the phone number before the web page address. People don't like hashtags. So we had this whole idea to do hashtags and online social. They're like, we don't care about hashtags. They also don't care about OHA or DHS, and in fact, they don't trust DHS as a brand, and so that was really eye-opening. So none of our materials are branded OHA or DHS, they're just branded OHP, and we had a lot of feedback that the logo should be sort of at the top of the flyer or the materials, so we've tried to make the OHP logo sort of front and center on the outreach materials. More information, you can go to ohpnowcoversme.org, but we have a lot of materials on there and more coming every day. So community-based outreach, it's not just important, but it's vital to this program and this effort. And really, every day I think we're having to remind colleagues at the state that our role isn't to do the outreach per se. Our role is to support the partners that do this outreach every day, and really just elevate that work. Again, we're dealing with a lot of sort of build it and they will come mentality, and so having to really question that every day. That doesn't work. And then also just really needing to raise awareness, I think, within our system that, again, immigration and privacy concerns are the #1 barrier we're experiencing. We're in a lot of uncharted territory. There's a lot we don't know, but at the very least, we should be equipping our staff and our community partners that are on the front lines of this work with facts, right? And it's been about a 1.5 year effort to really get a document together that we could sort of sign off on the state side to share with partners. But that is critically important to this work. People need to make, at the end of the day, empowered decisions, and these are hard decisions to make, right? But they deserve the facts, and so that's what we've been working on with our stakeholders and other partners, getting those facts around how data might be collected and shared with different entities for the purposes of administering OHP. Let's see, I think I've covered a lot of this in terms of best practices, but one thing I would highlight, just being a state employee, I think one best practice that we really held on to was having a project manager, especially since our program, as this was all sort of rolling out, we were moving from OHA to DHS, which further complicated things. So having a project manager that could just oversee all of that for us to address the siloing that often goes on in state government was really helpful. And then we're talking a lot right now about how we're taking all the lessons that we are learning through this effort, and how are we starting to look at applying this system-wide across the Oregon Health Plan. We're sort of in this unique position of shining, I think, light in places where it hasn't traditionally been shown. And I keep saying, if we can do it right for this population, I think we can do it right for a lot of populations. So why aren't we leveraging those lessons learned? You know, OHP logo, no other logo, those basic things. When we're doing outreach and communication, we should adopt that across the system. So that's what we're working on now. Challenges and opportunities, again, immigration and privacy is a big challenge. The cultural and linguistic responsiveness of the system is both a challenge and an opportunity. Again, we're learning a lot, and we'd like to see this applied system-wide. Language access has been really unbelievably challenging, despite the fact that we live in the year 2018. I just can't get over it, but it's been very challenging. And, you know, just resources. We have very limited resources, and so I think we probably all know, because we're in this room at this panel discussion, but it takes money to advance equity, and it takes long-term commitment, and that's not always an easy argument to make, but I will keep saying that. Thank you.
Thank you once again. My name is Amy Casso. I am the BRAVE Program Director at Western State Center, a 30-year-old organization who basically's mission is to build the power and resources for organizations and organizers. My particular journey here to this stage and to Ray, I was really connected to wanting to do transformative work, and in particularly based on my intersectional life. Coming from a farm worker family who didn't really have health care, to actually being able to do work in immigrant justice, and spending the last 20 years doing immigrant, racial, and health justice from Oregon to Texas, back to Oregon. And so I get the privilege of doing that, a really exciting work in a way that brings a lot of satisfaction and feels very transformative. My work in particular includes leading and working alongside of organizations and leaders of color who are part of the We Are Brave, Building Reproductive Autonomy and Voices for Equity. The organizations include Oregon Latino Health Coalition, Mono Family Center, Cabasas Leadership Institute, Momentum Alliance, as well as Apano. And we have actively been engaging and working together to really deepen our alliances across movements, issues, and as well as communities. It's really critical that we were strengthening our reproductive justice advocacy in 3 key areas, which was really political education, cultural shift, and policy advocacy. So as you see here in our victory picture and a couple of graphics, on August 15th, the governor signed the most progressive piece of reproductive health legislation in the country. And as you know, that really was about expanding and protecting a full range of reproductive health services, regardless of gender identity, citizenship status, and the type of insurance that you have, or how much money you earn. the spirit and the intent of the Reproductive Health Equity Act was really rooted in the community, as well as in the intersectional lives that they lead, as undocumented or transgendered, or as low income or underinsured or uninsured. And while Oregon has been at the forefront of many healthcare policy, there were still many that were being left behind. Disproportionately, we saw low-income, transgender, gender non-conforming communities of color, which were our communities, that were being left behind. And it was really important for us to really understand how the burden of navigating through those systems was having a tremendous impact on their social determinants of health. And specifically, we knew that about 48,000 women of reproductive age who were not eligible for Medicaid were lacking critical services to be able to access critical services and reproductive health services. So in 2017, we launched the Reproductive Health Now campaign, which was a values-based policy campaign to recruit, develop, and to mobilize reproductive justice advocates and partners in the passage of the Reproductive Health Equity Act. This historic win, it was historic, was really a proactive movement-building approach that included not only ourselves, Western State Center, but many in the Pro-Choice Coalition of Oregon, which included ACLU of Oregon, APANO, Family Forward of Oregon, NARAL Pro-Choice of Oregon, Oregon Latino Health Coalition, and Planned Parenthood Advocates of Oregon. And together we were really working to create a world where access to reproductive health services really didn't depend on who you were, how much money you earned, or what type of insurance you had. So when we think about this victory and this journey in particular, it was actually a 7-year journey. We worked with partners nationally who had conducted early assessments about what was the political viability of measures relating to immigration and abortion. And basically what they found that there were no politically viable measures. People felt they were contrasting interests. And in many ways, hence we were not to apply, but we did. And as you see here, we started that journey quite early on. In 2013, We Are Brave began by deepening its work in historically and in particularly most impacted communities by recognizing that our rights, resources, and the respect for all families were really critical. We were telling our stories to shape the narrative around what abortion meant. We were utilizing an intersectional lens in the work to help shape how we were talking about health inequities and what that meant for our lives. And more importantly, we were really focusing on body sovereignty as it relates to our own gender, sexuality, and as well as our own experience and histories. We recognized that there have been others, and in particular, there had been a lot of hard work by reproductive health and rights organizations that were being throughout the years put forth a lot of changes and significant impacts on reproductive health services. But I also want to acknowledge the importance of the stories that we were crafting and narrating that really helped to shape the Reproductive Health Equity Act. In 2015, we collectively actually launched the Comprehensive Women's Health Bill. I don't know how many of you know about this bill, but it was actually our first entree into drafting and developing and working collectively around addressing reproductive health services. It was, a piece of legislation that was going to speak to the full range of reproductive health before you got pregnant to after childbirth. And it was going to include 12-month prescription drugs, which we currently have on the books, as well as we were seeking out an administrative route for undocumented women. Well, after its failure, We did a little hard work around spending some time on just kind of reflecting about our challenges, our gaps, as well as the opportunities that we missed. I think we recognized that that parceling out and incrementalizing our bill really did leave us weak and vulnerable. And we didn't really actually have a bill that was really comprehensive. So in 2016, we spent the SORT session really being intentional about the policy development and, more importantly, about building a diverse coalition. I think Aldo and many others have talked about the importance of building a diverse coalition. And we did that around building around shared values, really putting the interest of the communities most impacted at the forefront of that work. And in the end, the Reproductive Health Equity Act really in its spirit was about making sure that no one is denied health care and reproductive health services because they're a low-income, transgender, gender nonconforming, or that they're undocumented. And so I'm going to pass it now to Leslie.
Thank you. I'm Leslie, and I work with the Reproductive Health Program here with the Public Health Division. And what I'd like to do is just to sort of give a little bit of context and background about our program and why, partly why we're so excited about this, but why it's so meaningful for the work that we're doing. So our program we have a diverse network of local providers who help Oregonians achieve lifelong health and live productive lives. Reproductive health is a basic human right, and the decision the ability for a person to decide if they want to have a family and the number of children they want to have and the timing of that really means everything. And so when we talk about lifelong health and productive lives, it really can impact that. Contribute to the achievement of equitable health outcomes for all populations in our communities. And then just ensure that Oregonians have access to high quality, low cost, client-centered services that are confidential. And more importantly for our program, or most importantly, we provide services where clients need them, when they need them, and in the way they need them. And that's really a hallmark of our program that we've had since the 40 years of our journey to get here today, which in 1970 we became the first Title X grantee in Oregon, and so some of those are from that. But so this is sort of the groundwork for our journey for implementing the bill from where it's passage until now. So our vision, it's really more than just birth control or pregnancy prevention. It's really that all individuals have access to, and access in all the many dimensions of access, not just that it's there. That all individuals have access to the knowledge and resources that they need and are empowered to realize their sexual and reproductive health goals and attain their full potential. So that's what it comes down to. And really high access to high quality reproductive health services and contraception are key to improving not only the health of individuals, but communities and future generations. Health equity and cultural responsiveness is one of the foundational capabilities of modernization for public health. And as such, it's inextricably linked to access because we can't have access without it. Just a little, again, by the numbers, just in 2017, to give you a sense, we served over 57,000 individuals, came through our doors and were served with contraceptive services. We have about 53 local agencies across the state and 149 clinic sites in almost every county across the state that are part of our provider network that provide services. And our biennial budget for this, the biennium that we're in right now, is a little over $34 million. Our funding sources had traditionally come from two main sources: the Title X Family Planning Grant, which was the only federal grant that is designated solely for the provision of family planning services for low-income individuals. and it's a grant, that has always helped to provide the capability or capacity to provide services. It never ever covered fully all the people in need of the services or the services provided. 1999, we got a Medicaid waiver for family planning, and we're able to launch C-Care, or Oregon Contraceptive Care, which allowed our ability to expand services to more people and more clinics. That's a federally matched program, 90-10 match, so it's pretty amazing. Just the hallmarks really quickly. These are the hallmarks of the programs that have been in place, as I mentioned, for 40 years. Easy client access. I think one of the things that when we say easy client access, it's all relative. We try to make it as easy as possible. All of these hallmarks are works in progress. They are always, it's an iterative process of continuous improvement, always learning and improving. And House Bill 3391, Reproductive Health Equity Act, is another huge opportunity for that. But so you can see the hallmarks: the access, the focus on quality care, national standards. We collect a lot of data, and we use that data to understand the needs and trends. We also share that data back with our local provider networks and our communities, so that they can help evaluate their areas of strength and sort of needs of focus. Quick overview. We are, as Amy mentioned, in August, the governor signed the Health Equity Act into law. We were really, really excited. We hung big signs in the windows of the third floor of the building. We were just totally stoked. This bill is very broad with multiple provisions, and it's very comprehensive, and I think that as Amy mentioned, that is in many ways that is a best practice, because what we've had before is just a history of piecemeal legislation, piecemeal funding opportunities to serve certain populations for a certain amount of time, and this is really going to help make something that's much more effective and much more sustainable. And with when you have that health equity lens, that reproductive justice lens, it really is much more meaningful. It takes something like this to get that done. One of the interesting things about this bill is that there are different agencies responsible for the different provisions, and you can see here the overview just quickly, that the Department of Consumer Business Services are responsible for the first three listed, which are the right to abortion, which is the right to receive abortion services, as well as provide abortion services in the state of Oregon. The non-discrimination, which really refers to this provision prohibits denial of services to eligible beneficiaries on the basis of actual or perceived race, color, national origin, sex, sexual orientation, gender identity, age, or disability by private health insurance companies in Oregon. The private insurance preventive services requirements. This is really great because it requires health insurance plans in Oregon to cover the full range of reproductive health services, including abortion, without any cost sharing. And again, for beneficiaries without regard to all the other things I mentioned before, and regardless of what happens at the national level, this is we will have this in Oregon. So then we have the expansion abortion services for individuals who would be eligible for services, if not for their immigration status, expansion of the medical coverage for women enrolled in COWM and COWM Plus, and then the big chunk, Section 5 of the bill, is coverage for preventive reproductive health services for, again, individuals who would be entitled to those services or be able to access those services if not for their immigration status. And that's another one that belongs with our program for implementing, that we get to implement.
Hey Leslie, you just got 5 minutes left if you want to ask questions.
Sorry.
Okay, that's okay. So these are just the primary changes to our program. You know, those hallmarks that are so critical, the foundation on which we built this, still in place. But now we've had an opportunity to restructure our program and in ways that's going to hopefully be more responsive to the needs of our provider network, the community, and more importantly, the community members that we serve. And I think, let's see, I'm going to toss it back to Amy to talk about best practices.
Thank you. I'll go quickly. I think when we talk about best practices, I think what was really important for us to be able to share with you, one is laying out the groundwork to this journey helps to actually think about the implementation for this work. We recognize that the way in which we built off of race, power, and privilege was a winning strategy in our policy. I do think it's a winning strategy in all key components to addressing health inequities. I'm skipping that one first. More importantly, like once again, we engaged those most impacted in helping to really develop the importance of community-driven solutions. And you know, the spirit of the Reproductive Health Equity Act is really about improving health equity for those who've been left behind. Building that movement really was really rooted in our lived experiences. It was rooted in, you know, the idea that there are generations on generations of people who don't know how to navigate and haven't had access. The other is that there are the current political and social contexts that we have to take into consideration. And more importantly, we have to think about the history and the cultural context for how we think about this work, not only from a policy and campaign perspective, but also in the implementation process. It is about the stories. They are case studies of improvement. They're about changing hearts and minds, and more importantly, it is about the data that exists. We knew that there were data and research that demonstrated a lot of this in terms of making sure that those engaged were leading the front when it came to finding out, identifying the solutions. And policy does matter. We dreamed really big. We seized on the opportunities to really envision, challenge, and to really fight for these reproductive freedoms that we all deserved. It was a values-based and intersectional is really critical so that all people can see themselves. And you know, as Leslie had mentioned, you know, often what has happened is that you know things that were related to us were really piecemealed in this work, and we were often getting left behind. And this is a way in which we said no longer we needed to all or nothing, and it was really critical for that to happen. And that is really one of the more important pieces, because I do think even noted in a Robert Wood Johnson report on health equity, they recognize the fact that you know, specifically addressing one factor of social determinants of health actually is not successful. And we saw that as well, and we recognize that because we all just don't live on just not one particular identity. Often we live multiple identities that need to be addressed. We wanted to shift opportunity and resources, you know, not only from a public health perspective, but also from a systems levels perspective. We needed to ensure that thoughtful, culture responsive care was being delivered. And we knew that in this work that we were doing, that, you know, our reproductive destiny was really intertwined to the conditions in our communities, and that means in the validation of our own human dignity. If you're undocumented and transgender, or if you are someone who's underinsured or uninsured, it was really important for us to be able to see all those components to be able to do that work. And I think that's really critical when thinking about how ways in which we advance health equity in a way that improves the lives of many. We are always seizing on the opportunities to really live and practice those values, and that also means in the way we think about the implementation process, and how it is important for us to also recognize how health inequities isn't just about the individual choices, but also the more important, the ongoing interplaying inequitable structures and policies and norms that often produce the ways in which power and resources are distributed across class, gender, race, sexual orientation, you name it. And it's really, I think, important for us as we're here on this weekend and here to talk about access for immigrant communities to recognize all of those aspects. Community partnerships, I think we've talked a lot about this. I think it's really critical. One is that we don't have to, we have to, I think it's important for us to recognize that authentic relationships lead to trusted relationships, and that we need to be able to leverage and optimize those partnerships in a way that we are maximizing our strengths and our assets in our communities. And that often means that we may have to take a step back or learn how to ask for help. And that in and itself will help to build in community ownership and buy-in that is really rooted in, I think, the success of if it's not Cover All Kids, or well, let's call it Oregon Health Plan, or if it's, the Reproductive Health Equity Act and the way we are doing this work. What I will say is on both ends here that you have a deeply invested stakeholders. We have been there from the beginning, and we're here till the end because we actually want to see it actualized in the streets. Because we want to see the lives in which that we sought to address. They actually get to benefit from this really exciting stuff. The other important piece of this work is really to continue to do important cultural shift work. And at the systems level, at the way in which we deliver services, and a lot of other ways. One and not done, that is, and when addressing health equity, it is not just one thing, it is an ongoing process, it is multi-pronged. Things are shifting consistently. As Josie has said, on the ground, our communities are often fleeing, and seeking ways in which they can feel some security in this work. Issues of privacy and security are very relevant. If it's not just in 558, it is also in 3391. And we have to also be open to the idea of change and dialogue and being transparent in the communications that we're offering and how we work with communities. I think it's really critical because often what has happened, it has been in our experience that working at the policy level hasn't always been in our benefit sometimes, and sometimes we get disillusioned. So the idea of how we're navigating that system is really critical, and being transparent about the process is really important. We needed to pay attention to process. How you engage people is really important, and how you interact with them in a way that they're able to craft agendas as well as when able to stop when things are not going right. And then also to be mindful of history. We have, many of us and many communities have had opportunities, haven't had a lot of opportunities, and the histories they have had haven't been in accessing abortion or knowing where to go to when it comes to accessing healthcare and reproductive health care services. And so kind of with that being said, I just wanted to make sure that, hey, it's really exciting to be doing this work and for all of us to be on this panel together, because I think that we're really truly invested in seeing it being successful, and not just in the context of its policy, but more importantly in the implementation that is changing lives.
Thank you, Amy. I know we're over time, right?
Yeah, I just want to do a quick time check. If we are time, so if we have to get up and leave, that's totally okay. I think our panelists are more than happy to stay and answer questions if you do have questions. But I just want to say how grateful I am to hear these stories. I think this week we've heard a lot about what we're not doing well at, which are good, uncomfortable conversations to have, but these are such great examples of where we're actually getting it right, you guys. We're doing it right here. So just thank you so much for being here. And if there are any questions from the audience.